Good morning. I would be speaking today on gelastic or laughing epilepsy, which is caused by an enigmatic pathology, hypothalamic hamartoma. It's an uncommon cause of seizures, but as we are treating more and more cases, we do find that the incidence is not so rare. Now, I would show a short video. So this is called as a mirthless laughter or a forced laughter. The child doesn't like it, and often after this episode, the child starts crying. And this was first described in the year 1873 by Trezeu, and it comes from the word gelos in Greek, which means mirthless. Now this is a hallmark of hypothalamic hamartomas, and as you can see, these are repeated short-acting seizures characterized by mirthless laughter or grimacing, and they are typically arise in childhood and often in the neonatal period. And these episodes are drug resistant and they have to undergo treatment only surgically. Now, hypothalamic hamartomas are congenital non-progressive lesions. All of them arise from the floor of the third ventricle and anywhere between the optic chiasm till the mammillary bodies. And it's an uncommon condition. It happens in 1 to 2 cases per lakh. But when it happens, it has to be diagnosed properly and treated properly because they are completely amenable surgically, provided give the proper surgical approach. Now, as already mentioned earlier, hamartomas present typically with gelastic epilepsy in 60 to 70% of the cases. Approximately 10% of the cases, they could also present with precocious puberty. Most of them have psychiatric and behavioral disturbances. Now, 90% are sporadic and 5 to 10% could present genetically, and this is called as Pallister-Hall syndrome. Now, as I've told you, the disease burden, it's uncommon, but it's very important to identify and then treat this condition because it's treatable completely through the proper surgical approach. Now, as I've shown here, the hamartomas could be sessile or pedunculated. So when it is sessile, it is connected to the posterior hypothalamus, presenting typically with gelastic epilepsy. And when it's pedunculated, generally it's connected to the anterior hypothalamus and presents with central precocious puberty. Now, gelastic epilepsy, normally they present in early childhood, but as the child becomes older, usually more than 10 years of age, the gelastic epilepsy fades with time and the other seizure patterns start evolving like focal or generalized seizures. Now, the reason why this kind of seizures occur is because of the intrinsic epileptogenetic mechanism of hypothalamic hamartomas, which consists of small or immature neurons, which are GABA receptor mediated. And this is what leads to generation of seizures. Now, central precocious puberty could happen in about 10% of the cases, and they're characterized by breast development and in males, increase in testicular volumes and as well as size of genitalia. And they could, generally in such cases, they do not have neurological problems like epilepsy. Now, this is an example of a child, very rare case presented to us both with precocious puberty as well as gelastic epilepsy. And as you can see that the child has well-developed genitalia, and also you could see that the build of the child is also much more. Now, about 50% of these patients, they develop progressive intellectual disabilities, and there could be a number of contributing factors. Some of them include the young age of seizure onset, the larger size of hypothalamic hamartoma correlating with this, and also the child being often on large number of anti-seizure medication, which again leads to cognitive issues. Now, rarely apart from gelastic epilepsy, they could also present with rage attacks, but these are much less common. However, psychiatric symptoms have been reported in 80% of the children. Now, histologically, hypothalamic hamartomas consist of clusters of small neurons intermixed with glia and large neurons. And neuronal clusters are described as configuration of grapes, and they have low levels of Ki67 indicating a low proliferative capacity. As described earlier, 95% of these cases are sporadic, the cause is unknown, and 5% are genetic and they are mediated by the GLI3 gene. Now, GLI3 gene mutation is again takes place through the sonic hedgehog pathway. And the condition of Pallister-Hall syndrome as a result of this is very, very uncommon. Less than 100 cases have been described worldwide. This is one of the cases which we have treated. And you can see that the child has syndactyly, polydactyly, as well as they could also present with imperforate anus. Now, diagnosis is performed using the video EEG, clinical semiology, and doing a proper MRI. Now, when we do an MRI, we find that the lesion arises from the floor of the third ventricle. One way to remember is that pedunculated is often associated with precocious puberty, whereas sessile are associated with seizures, which are gelastic epilepsies. CT scan reveals an homogeneous isodense lesion, which is not enhancing on contrast. And one has to have a high degree of suspicion in order to make this diagnosis on CT scan. But it's very important for us to do an MRI following a CT scan. Now, MRI again definitely shows a lesion in the floor of the third ventricle, which is not enhancing. And again, presence of calcification and hemorrhage are very rare. However, if the lesion becomes a giant tumor more than 4 centimeters, sometimes areas of cystic changes could be seen. Now, MR spectroscopy is an adjunct investigation, which may be done in order to increase the likelihood of diagnosis, and that reveals increased myoinositol and choline. Now, there are several classifications of hypothalamic hamartomas, including the earliest one by Boyko et al., who classified it as pedunculated and sessile. But the one which is most commonly accepted are one by Professor Delalande and Folin, which have 4 grades of tumors. So type 1 is where the tumor is below the horizontal level of third ventricle. In type 2, it is attached to one of the walls of the third ventricle. In type 3, the tumor can be both above and below the level of third ventricle. And type 4 is a giant more than 8 centimeters or above. Now, few examples of this, which we have seen in our cases. This is a type 1 Delalande. Could be seen that it's on one side. Type 2 is arising from one wall of the third ventricle, and again confirmed MRS. Type 3, it arises both above and below the level of the third ventricle, and type 4 is a giant hamartoma. Now, hamartomas very rarely could also happen in other areas of the brain, and we have described 2 cases of cerebellar hamartomas who also presented with seizures. One patient presenting with status, which we have published. And following surgical resection, the patient was completely free of seizures. This again emphasizes and reiterates the intrinsic epileptogenic mechanism of cerebellar hamartomas. Now, differential diagnosis, once we see this kind of picture, rarely we could consider any kind of diagnosis. In fact, the clinical semiology, the video EEG, and presence of such a lesion on MRI is a sine qua non for diagnosis of hypothalamic hamartomas. But for the sake of academic discussion, one could also consider an hypothalamic chiasmatic glioma. But invariably, most often we find that these lesions have an heterogeneous enhancement. You could also consider other pathologies like a germinomas or a craniopharyngiomas or a dermoid cyst or a choristoma, or very rarely other things could also be considered. But as I have told you earlier, with this kind of triad of clinical picture, video EEG findings, and the MRI imaging, it is unlikely that we could ever think of any other diagnosis. Now, in management of hypothalamic hamartomas, it is to be reiterated that medical management has no role. Anti-seizure medication hardly work. They may reduce the frequency and duration, but they are almost never control it completely. Ketogenic diet is also of minimal benefit. So the only strategy which could be thought of is a surgical strategy. Now, historically, if we see, Northfield and Russell did the first successful resection of hypothalamic hamartomas. But over a period of time, people realized that doing resection of such lesions are associated with high degree of morbidity. And one of the reasons being that they are actually normal areas of the brain which have abnormal connectivity, and they're supplied by the normal blood vessels. So if one tries to resect, you could also compromise blood supply to rest of the brain, which again leading to significant morbidity. So people realized over a period of time that it is better to disconnect them rather than to resect these lesions. Now, early on, people would do the microsurgical approaches, open surgical approaches. They're still practiced in some centers, and we would completely discourage it. And they have been given up in most of the centers, and we will say that this should not be done at all because they're associated with a very high degree of morbidity, almost 30 to 40%. And you could have various approaches like a T-renal, transcallosal, transtemporal, etc. Now, endoscopic approach a decade back were very popular, and they have been developed by the Barrow Group. Now, in endoscopic approach, you could pass an endoscope using navigation through the ventricles. The advantage is that it's minimally invasive, has excellent visualization, provides a panoramic view. But the main disadvantage is that one does require a significant learning curve. And it's always a challenge to pass endoscope through slit-like ventricles, even with using navigation. And it could be done only for the smaller grades of hypothalamic hamartomas. Now, this is an example of an hypothalamic hamartoma, grade 3, which we have treated more than 15 years ago. And the child presented with both precocious puberty as well as seizures. So using navigation, we were able to perform an endoscopic disconnection. And this is a video just to show how the endoscopic disconnection is being performed. So we visualize it, go there, and then start cauterizing, and then start performing the disconnection. And post-op, you could see that a very nice disconnection has been performed, and there has been a remarkable improvement in the child. This is the pre-op and post-op. You could see that there is a complete change of the facial structures, and there is a significant improvement of the hormones. So we performed this procedure in about 7 cases, after which we evolved to much better techniques. Now, among stereotactic procedures, one could think of gamma knife, but it's not recommended anymore. The reason is because of the very low frequency of seizure freedom, less than 40%. And there is also risk of radiation to the surrounding diencephalon because it's located in a very crucial area. And there's always a delayed response of more than 1 year, which again increases the risk of encephalopathy during the interval time. Now, laser interstitial thermal therapy has become very popular in the West. We did it in one case, and this is the child where we did the LITT for a small hypothalamic hamartoma. Now, the main issue or the main problem of LITT is that it could be used only to treat the small hamartoma, but the main problem is you cannot use multiple trajectories. So that is a major disadvantage with LITT. Now, radiofrequency thermocoagulation using a frame-based system is effective, but however, it takes a long time because when you use frame in order to provide multiple trajectories, it takes a longer time. But in terms of technique, it's quite effective. Now, what we did is we combined the robotic guidance along with the radiofrequency ablation. So rather than using the frame-based system, we combined it with the robotic system. And this was for the first time in the literature this technique was described by us. So this is the OR setup we use. We use the Electa system. We also have these adapters, and we have a combination of both the O-arm as well as the ROSA system. Now, it's very crucial on planning the trajectories well. For instance, one has to plan trajectories in such a manner so that one provides a radiofrequency disconnection. So we don't burn up the entire lesion, but we produce a radiofrequency thermocoagulative disconnection so that the hamartoma is now effectively disconnected from the rest of the brain. Now, again, this is an image which we have taken from Professor Kamiyama, which shows that in type 3, you do a bilateral approach and then disconnect the hamartoma bilaterally. Now, using Lexell's pulse generator, we burn for about 60 seconds at the temperature of 75 to 80 degrees centigrade, which is effective to produce a very good disconnection. This is a short video to show how the procedure is done using the robotic system as well as O-arm. This is a patient. Now, this is not the patient with hypothalamic hamartoma. This is an adult patient, but we just wanted to show how the ROSA functions. So once it's registered, we use drilling using only a twist drill. So we don't use a burr hole. And following this, the length of the electrode is measured. And then we gently insert the electrode, which goes up right up to the target point. So one has to rotate the electrode carefully. And then we do a fusion with both the MRI and CT scan to ensure that the trajectory is absolutely accurate. So there's an overlapping of the robotic trajectory, proposed trajectory with the actual trajectory. And this increases the accuracy of the target to almost 100%. And one can see the disconnection here at the end of the procedure, where we have not burnt out the entire hamartoma, but we produce a very good disconnection using radiofrequency thermocoagulation. And that is the whole objective of the procedure. Now, we learned this technique from Professor Kamiyama, who have had a large experience of more than 200 cases now. But they do it using a frame-based system. So we combined it with a robotic system. Now, in our experience, I have performed such cases in microsurgically 6, and I gave it up very soon. And then we evolved to the endoscopic technique, in which we did it in 7 cases. And then we performed it in 1 case of laser interstitial thermocoagulation, which we performed as a part of a workshop. And then finally, we settled down to robotic guided radiofrequency thermocoagulation, which we have performed in about 17 cases. As it can be seen here, the majority of the cases are grade 3 or large tumors. Now, these are the breakup of all the cases. And as it can be seen here, majority of them are grade 3 and some of them are grade 4. Now, 16 out of 17 have had class 1 outcomes, which is very good. There were no major complications and all the patients have recovered. Now, in some cases, we had to repeat the surgical procedure because of leaving behind a skip lesion. But I think that is quite okay, because doing a second procedure is also straightforward and minimally invasive. You do it through a twist drill. And following this, the patient was completely seizure-free. Few examples. This is a class 1, type 1 hypothalamic hamartoma following radiofrequency thermocoagulation. Example of a type 2. And again, robotic guided thermocoagulation. We produced a good disconnection. So an example of a type 3, as you can see, the lesion is both above and below the floor of third ventricle. And following disconnection again, the child was seizure-free. This is a giant hamartoma. It could not be done by any other procedure. So we could, surgically, it was open surgical, it's totally inaccessible. So using the robotic guided thermocoagulation, we used 7 trajectories and produced 40 burns, and we were able to produce a very effective disconnection. It's an example where we had a residual pedicle following initial surgery, and you can see the residual pedicle over here. And doing a repeat procedure, the child was again seizure-free. So in our experience, we found that robotic guided radiofrequency thermocoagulative disconnection for hypothalamic hamartomas is a very safe technique. It's very accurate, it's very effective. It's faster because you do it through the robotic system. 16 out of 17 cases in our surgery had a class 1 outcome. It's frameless, it's minimally invasive, has a very low incidence of complications. And because we work at a government institute, the patients only have to pay for consumables and not for the equipment. It is very, very economical. It costs only 5,000 rupees per patient, which is effectively $65. And that is very economical to treat this very complex pathology. So these are some of our published work on the robotic, where we developed the robotic guided thermocoagulative disconnection for hypothalamic hamartomas. So before I conclude, again, I would like to acknowledge our entire epilepsy team. So such kind of complex works is possible only when you have a full team. So Professor Manjari Tripathi, who works up all our epilepsy surgery cases very, very effectively. Professor C.S. Bal from nuclear medicine. Professor Gaikwad, head of neuroradiology. Professor M.C. Sharma, head neuropathology. Professor Madhavi, again from nuclear medicine. And Dr. Ramesh, my own very colleague, who helps me with all my cases. Dr. Ashima, our clinical psychologist. Dr. Jyotirmay Banerjee, who is a professor of intracellular electrophysiology division of our COE lab. And Dr. Aparna Dikshit from the molecular division. I would like to thank our fellows, Ravi and Nihal, who we have a 2-year fellowship program. So for people who are interested to pursue this fellowship, it's a high volume center and you get to learn a lot. you could apply this through the entrance exam, which we announce every year. So thank you very much.